I'm going to kick off now. So thank you everyone for joining us tonight on this Discover Rural Generalist training with the RACGP. I'd first like to acknowledge the traditional custodians of the lands and waterways in which we work and live, and recognise their continuing connection to land, water and culture, and pay our respects to elders past, present and emerging. And I'd like to pay my respect to any Aboriginal and Torres Strait Islander colleagues here tonight. Just a few housekeeping before we get into the nitty-gritty of it. You won't be able to speak because the mic is turned off for you, and we won't be able to see you. But this webinar is being recorded so you can access it at a later time. If you have any technical issues, there's a number there, and Maddie will put it into the chat box as well, so that you can call that number if you have any issues with your IT throughout the webinar. If you have a question, just type it into the Q&A. We will answer the questions at the end of the session. If someone else has already asked that question that you have, give that a thumbs up. So the more thumbs up a question has, the more likely it will come to the top and we'll address it. So we won't be answering any questions throughout the presentation. We will address them at the end when everyone's finished speaking. So if you have any specific questions that's related to your individual situation, do email us, because we try and address everyone's questions, but if it's very specific, it may be better to have a one-on-one conversation. So there's a become a GP at racgp.org email address there. So keep it handy. If you have any specific questions, or if we haven't fully addressed your question, contact us, because we're really keen to help you. And then lastly, housekeeping, we want to thank our event sponsor, the Rural Doctors Association of Australia, who's one of our close partners, because we share a common vision of excellent medical care for all rural and remote communities. The RDAA actually represents the interests of rural doctors, as do we, and their communities. They're committed to building and maintaining the workforce of highly skilled and motivated rural doctors with adequate training, proper incentives, remuneration and support. So everything for rural doctors. Tonight's session, we're going to move through it quite quickly with some of the details about our Rural Generalist Training Program. I'm Karen Jodlowski-Tan. I'm the National Clinical Head of Rural Pathways at the RACGP. I'm also a rural generalist and a rural GP, working mostly in very small country towns and in Aboriginal health. I'm joined by Dr. Jane Long. I've called her doctor. Jane is one of our rural program managers, and she's based in South Australia. So she'll give you some of the program details in our presentation. But I really want to then move quickly on to our three rural generalists who are here to share their stories with you. So Dr. Travis Boon, Dr. David Lam, and Dr. Pip Knowler. So more about them when we come to their session. But for now, let's a little bit about you. I believe Maddie is going to put up a poll. So is that right, Maddie? Have we got a poll? Yep, there's a poll. If you can just quickly answer that poll, we can find out a little bit about you and who is here with us tonight. So when everyone's polled, will you share the results, Maddie? I think everyone's had time to vote. Not sure how this works actually. About 4 more to go. Great. I'm not sure if everyone can see the phone number for technical help. Maddie, you might have to post it to everyone. Okay, so we've got almost a third of you are medical students. I'm very pleased to see your interest in rural journalism, and then most of you are PGY2 onwards. So that's excellent. I'm very, very pleased to see your interest in becoming a rural journalist or rural GP. So let's move on. Let's talk about what it is. The RACGP, or Royal Australian College of General Practitioners, has been around for a long time. We started training doctors back in the 1960s. So we've had 60 years of experience. Our membership has grown to around 50,000 members, and about half of them are actually members of rural faculty. We have about 9,500 to 10,000 rural GPs working in rural locations and represent about 4 out of 5 rural GPs. And in terms of training, 90% of GP registrars are training with the RACGP. Currently, we have over 440 rural generalists in training, and we have wonderful online resources, hundreds of clinical resources, and a lot of them are national standards, and people often refer to our national guidelines. With the RACGP, you can actually train towards being a GP who works rurally or may not work rurally, but you can also train to become a rural generalist. Our GP training program, if you don't want to become a rural generalist, you can complete it in 3 years. If you want to be a rural generalist, there is an additional year of training, so that it's a total 4-year full-time equivalent program. Just quickly share with you what's a rural generalist. There is a Collingwood definition. A rural generalist is a rural GP. That's the core of it. They work in general practice, but they also provide extended scope of practice. So they may have additional non-GP specialist skills, plus they provide emergency services for their towns and communities. So for example, here you can see Dr. Izzy. Her week looks like time at the hospital, time doing her advanced skill, time working in the practice. It is quite a rich lifestyle working across those things, and you'll be able to see that when all our rural generalists share their stories with you. So it just makes your working and your career much more interesting to be able to work across the community as well as providing secondary care in the hospital as well. Now, you can choose to become a rural generalist anytime that suits you. You can choose it right at the outset when you apply. You can tick a box and say, I want to become a rural generalist when you join our training program. Maybe sometime during your program, you decide, maybe that's what I want to do. I want to go rural and I want to stay rural and I want to get an additional skill to service my community. So you can let your training coordinator know anytime during your training that you want to become an RG, and then we can support you to map out your journey, how you're going to get all the skills and training you need. Or you can complete your GP training and then later on in your career complete additional skills training and more emergency skills training to become an RG. So it is very flexible. So how does training work? Here's a little graphic which may look a little bit busy, but it's a bit of a breakdown from the previous diagram where if you just want to do the RACGP Fellowship, the first year is usually a 12-month hospital time where you complete a range of rotations to ensure that you cover general medicine, general surgery, emergency, and pediatrics. And then the next 2 years is spent mostly in general practice. You need at least 18 months in community general practice with 3 6-month terms, and then additional 6 months, which we call extended skills. Now, that could be an extra 6 months spent in general practice, or you could be doing some other skills that's relevant to general practice. So some people may choose to do more mental health training in a special service or some palliative care or dermatology. So there's a whole lot of things that you can do in that extended skills term. And it could be in community or in hospital setting. With a rural generalist, I talked about the emergency component before and the additional rural skills training. So that additional rural skills training, depending on what you do, can be done anytime during your training. It could be done up front at the start, depending on when you can get the training you want and when positions are available, or it could be done towards the end of your training. So it really depends where you're training as well, because in some states and territory, when you're offered those positions will vary. So again, there's a lot of flexibility about when you do these things. Just a quick word about core emergency medicine training. Every rural generalist is expected to provide emergency support and on-call services, usually to their community, and that's part of being a rural generalist. So we expect everyone to attain a certain level of emergency skills, and our program requires the equivalent of 6 months full-time emergency training in accredited locations. So it has to be an emergency department that's open 24 hours a day. There should be a supervisor available to support you who are appropriately qualified, either a FASM or someone with the equivalent of the advanced diploma in emergency medicine, or a rural generalist who's been practicing emergency medicine for 3 or more years. But they all have to be committed to support your training in that scope. So, where can you train? Well, that's an interesting question, because everyone comes to it with a different perspective. Some people may be from a region and then they decide, I want to come back and work in this region, or they really like a certain location and say, I really want to work in this community. And then you have to look at what the community needs as an additional skills. So you then choose the discipline that you want to do that extra training in. For someone else, they might say, oh, I really want to be an obstetrician. So then you do the training, but then you would have to find locations where you can later on practice your skill and continue to keep up your scope of practice. So there's no point going to a small town where there's no delivery services, no maternity services. So that will decide where you eventually practice. So, have a think about which perspective you're coming from. Training location is very flexible. So in the hospital year, you can choose to go to any accredited hospital for your training, provided you cover those core hospital rotations that I talked about earlier. You need to complete the emergency training. Again, there's a lot of places where you can do it. You can do it in a major hospital. You can do it under the ASIM Training Foundations program. You can do our curriculum, and your training program team will help you decide how you want to do this. We've talked about additional rural skills training, so I'm going to hop past that because Jane will tell you a bit more about that. And then community general practice terms, of that, you need to do at least 12 months in a rural general practice in an MMM 3 to 7 location. So that means modified Monash model 3 to 7, and it's a measure of rurality. So on the map, choosing your region and pathway, you can come into this on either what we call the general or rural pathway, and I believe there's another webinar that would have explained all this, but just quickly, the general pathway allow people to train in MMM1, which is metropolitan, to MMM7, which is the most remote locations. So if you're in general pathway, you can train in city to remote. If you're on the rural pathway, you train on MMM2 to 7, so you can train everywhere except in very metropolitan areas. But it doesn't matter which pathway you're on, you're all very welcome to become an RG with us, and we will support you the same. Now, I'm going to hand over to Jane, who's going to talk to you a little bit about the specific additional rural skills discipline. So over to you, Jane.
Hi, everyone. Just a little bit of extra information about the specialties you can specialise in. So the RACGP has, as you can see on the map, more than 350 accredited sites across Australia. And as Karen mentioned previously, you can apply. You can do this ARST regardless of the region. You can apply to any of the positions if that's what you want to do. So I guess the scope of that is you could do small town rural general practice, which you would complete exactly as it sounds in a small town in a rural general practice, or you can do anaesthetics, adult internal medicine. You can do an academic post, child health, which is paediatrics but has a community component as well, medical education, mental health. With obstetrics, anaesthetics and emergency, you use the curriculums of those particular specialist colleges. With the other specialties, we have curriculums that are tailored. On top of that, we can create what we call a bespoke curriculum if there's something you're particularly interested in and we haven't got a set we can take off the shelf. So yeah, lots of choice there. So just go on to the next one, I think, Maddie, would work. Okay, so just seeing if I've got that one. Securing a ruralist generalist placement. So some ARST hospital positions are managed by state rural generalist coordination units. Others might be through the state health application system, so that does depend. If you join the program and you've already got an ARST lined up, the program team will work with you to ensure that the hospital can meet the requirements of the curriculum and it's accredited before you start. So that would be in particular, say, palliative care, because it's our curriculum, we'd go in and meet with them and get all of that paperwork done. If you don't have a position, the program team will liaise with you and the RG unit if necessary, or the local health network if that's the way it works for you, to coordinate the placement. And just so you know, you may be required to go through a competitive interview process for some ARST posts, for example, anaesthetics. That is a very structured interview process in most states, so that there's a little bit of variation there. We can probably move on to the next one, Maddie, if you like. Oh, sorry. So how are you supported during training? So you will have heard Karen previously talking around training coordinators and program teams. So this little diagram probably explains it the best. So as with all registrars, you'll have your clinical supervisor. You'll also be supported by your medical educator, and they'll give you that educational expertise and mentorship. Then you have a training coordinator and a program support officer who helps you with everything to do with placements and payments and all the advice you need. But as a rural generalist registrar, there's that extra layer of support that really focuses on the rural generalist aspects of your training. So that's a rural generalist medical educator. So that'll be someone who follows you right through, not just when you're doing the ARST, but actually you'll talk to them probably at least every 6 months, if not more. Rural programs admin officer, and somebody like me, a rural programs manager. So we get looped in at various stages, even sometimes right at the start. If you've got questions during application, you might even talk to us then. We can probably move to the next one. Education and feedback. So the RACGP, it is like an apprenticeship model of general practice, and it does have a robust out-of-practice education program. So you'll get your on-the-job training with your supervisor, which is scheduled one-on-one teaching time, I guess. You'll also learn from medical educators, and we have face-to-face workshops that you'll meet your peers, which gives you great chance to sort of explore cases that you've seen throughout the month. They're fantastic. Journal clubs, webinars, excellent exam preparation workshops, really, really brilliant support there from the college, and lots of online modules. So I guess our focus is on small group learning with that bit of online as well, and it does mean that you've got that time to connect and learn from everybody, and we think that does better equip you for a successful career in general practice, which, as we all know, is collaborative in its being. Okay, so financial supports and subsidies. So this is some of the great news that we get to share with you, is that there is a lot of incentives for you to go rural, and the college we sort of navigate and support these programs through the training program. So then there's lots of, I'll start with the nationally consistent payments. So they are paid to registrars for each 6-month general practice training term in MM2 to 7. So that's all the rural locations. They are scaled via rurality and go from, as it says there, 1,800 right up to 9,250 if you're in a triple M7. So in that middle range, it's around 3.5, 4, 5 grand, and that just goes into the bank account. The other bucket of money is the flexible funds, and these are very targeted incentive payments that apply to specific locations with workforce needs, and they range from 5 to 45,000. And they're more of a reimbursement process, and that might be for things like respite, travel, relocation, professional development, childcare, lots and lots of things, and we can give you more detail about that. The Workforce Incentive Program, the WIP, you may have heard of that. That's not just for registrars, that's for all rural, and you can get more information about that. I won't go into too much detail. There is a $6,000 payment for you when you do your ARST year, which is fantastic to help you maybe do some courses or things, or any enrolment fees you might have. Then there's the debt reduction for your HELP debt that you may have, and that can really help if you work in those MM3 to 5s and above the 6 to 7 for some of your time. So we can give you more information about that if that's something that you're interested in. And on top of that, if you did happen to do your ARST first, you would have access to the Rural Procedural Grants Program. They go up to $32,000 to help you continue your professional development in your procedural and emergency medicine skills. Okay, I think, Karen, we were going to go back to you for the next one, but I think I can do that one as well if you like, unless you want to join in. So it's all about why choose the RACGP, and I think Karen and I both could talk about that for hours. I guess with us, you're not locked into one training program or career pathway. You can commence as a rural generalist. If life changes, things get in the way, you can opt out. You'll reduce your program time and still become a specialist GP and be able to work anywhere in Australia, every postcode, every community. I think that's probably the thing. The college, the RACGP, we recognise that crucial role of primary care for healthy communities to keep people well, and that's why we emphasise community general practice in our training program. Managing chronic disease is longitudinal, and it takes time to develop the skills and that comfort in managing that uncertainty of life stages. So we think you receive a good balance of hospital and primary care. Without going into too much depth, I guess, regardless of reality, you have access to the clinical guidelines, resources and training. We deliver the small group learning in remote and rural locations. Everything online is the same for everybody. The content's developed by GPs for GPs, which is brilliant. And I guess at the end of the day, we deliver the most rural doctors to rural Australia. 4 out of 5 rural GPs are RACGP. So I won't go into any more detail unless you want to add anything to that, Karen.
That's wonderful. Thank you, Jane. I think we'll move on because we are raring to hear from our rural journalists. So there's a QR code there for more information or to contact us, and letting you know that our applications are now open until 8th of April. So, yeah, you can zoom in and find out more. But I'm going to invite Travis now to show himself and join us. He's our rural journalist from Queensland, and he's going to tell us his story of how he's training towards becoming a rural journalist with emergency medicine as his additional skill. Travis?
Cool, thanks, Karen. Yeah, so so my name's Travis. I'm working in Queensland, and I'll go to my next slide and briefly talk about my journey. Was an RMO for a few years in Toowoomba, and sort of had to do a few rural relieving terms, which I really enjoyed, and that kind of made me want to do more, I guess. And then I moved from Toowoomba. I got a bit over the hospital grind and wanted to get into general practice. So I went to Bundaberg and worked at a Aboriginal Medical Centre in Bundaberg for a year, and had a really, really well supported and good introduction to general practice, with lots of face-to-face learning and a really good supervisor as well. And then obviously rural journalism was the interest, and decided on ED as a skill, advanced skill, which I did in Bundaberg as well, and spent 18 months there in the ED, and worked towards the advanced diploma, which now got another name, which I keep forgetting. And now I'm working at Theodore, which is working both as a MORP, so medical officer with right to private practice, and also finishing off my GP registrar time there at the medical centre. I'll go to my next slide, thanks. So a little bit about Theodore briefly. We're not that far away, really. I think it's about a 6-hour drive to Brisbane and 2.5-hour drive to a coastline. So pretty much still in the southeast part of Queensland. But it is quite a small town, and there's about 450 people in town. But we do see a lot of people from all over. People travel a couple of hours to come and see us. I think the practice has about 1,500 active patients. The really great thing about where I work is that 90% of my time is in general practice, but then I have a hospital basically next door that I can admit patients who I feel need to be admitted, and don't have to argue with anyone to get them into hospital, and I can admit people who probably in a regional or city landscape would not get an admission, but I can admit them for my own sake and for their sake, and probably for the fact that we have limited resources, and admitting a patient gives me just as much information as a CT scan or some formal blood tests that get done in a lab at times, not always, but and I'll go to the next slide. Thanks. So the medical centres on the left there. So a little bit about just the previous slide. A little bit about the medical centre. So I'm actually got a full-time contract with the medical centre and a full-time contract with Queensland Health. Obviously, I don't do, what does that work out to be, like 80 hours a week. But how we usually work is we meet at the hospital every morning for an hour and round on inpatients. There's only 10 beds, and 4 of those are taken up by permanent high care nursing home patients. So really only 6 acute beds. And then pretty much after that hour in the morning, spend the rest of the day in general practice. And if you're on call, so there's actually 4 doctors that work in the medical practice. 3 of them are attached to the hospital. So we're on a 1 in 3. We do a whole week on call. If you're on call, then you might see the odd patient in the hospital, but then go back to your GP patients. And it's set up quite well that most people will come to the practice rather than the hospital, and we can actually sort out a lot of stuff in the practice. We've got our own little ED set up there as well if needed. Obviously we've also got the hospital if we think that they need to be admitted, but it does work out quite well. And the on-call isn't too strenuous. Like, you might be strapped some weeks, and then other weeks it might be a bit better. And some weeks you might only get one phone call overnight, and other weeks you might have to go in. But it's on average, it's actually quite good, I think, because it's a small town and we've got 1 in 3 on call. That middle photo there, that's my son. If I get out on time, which I'm getting better at, I'll head over to the golf range and push him around and give my wife a break from him for about an hour and a half, and shank a few balls into the adjacent paddocks. And then the other photo is just like we did a multi kind of department or service scenario, and you get to know everyone. So you get to know the police and the AMBOs and SES and fireys, and which all has its perks, especially with the police. And we'll go to the next slide. I thought I would try and obviously talk about my experience and also what I think might be some good tips. So it like the pathway can be complicated, but that's because it's flexible. So myself going GP and then back to the hospital and then GP and then and that's because that fit in with my life and where I was at the time and my family and stuff like that. So whereas a lot of other specialty pathways will just say, no, you do what we say, and otherwise you can go find another training pathway. But it's complex because it's flexible and there is support available. And there's the Rural Generalist pathway, which is not essential to be a part of, but it is another support service. I've found them to be quite useful, and also obviously the college you're training with. Karen remembers my name because she was very useful in supporting me when I had lots of questions about ED training and the transition between the RACGP and the RG Fellowship. ED time is essential and now mandatory, mainly because if you are going to be covering a hospital, if you want to not be too anxious all the time, it does pay to have some ED training. I certainly didn't enjoy ED as an RMO, but I enjoyed it a lot more as a registrar. And I would recommend that if anyone was interested in doing more ED time, then to do like a PHO or registrar role, and it is much more enjoyable than as an RMO, I found. With regards to procedural versus non-procedural based ASTs, there's pros and cons. So procedural, you're going to have, more probably scope to do things completely separate from general practice, and that obviously makes things nice with having to do lots of different things. But yeah, it does limit where you can work, obviously that, especially in Queensland, they're trying to do their best to get more birthing services available, which is where obviously anaesthetics and your ONGs obviously can work. But at the moment, it is quite limited places. Whereas the non-procedural based ASTs, you can do those anywhere and you can work anywhere. You just need a room. The ED for me means that I can work anywhere. Because there's always a hospital to cover and a general practice to work at pretty much in all rural towns. And then the last thing is location matters. So, there's lots of jobs available for rural generalists, but I would do lots of research into those jobs and how well supported they are. The reason why I'm having a great time where I am is because there's three doctors that work at the hospital in a town of 450, which is pretty crazy. When pretty much 500 kilometres around me, there's only a handful of doctors that work in much bigger places, but they get burnt out quite quickly. And I think you really need to pick where you work, and having someone that's going to be a supervisor and be supportive and ideally not too locum heavy. I think it makes a big difference. And I think if you were wanting to go straight into rural general practice, I think it does help to have a bit of hospital experience and a bit of maybe even your AST done first. Although in saying that, I benefited greatly from my regional time as a GP registrar for my first year because I was so well supported, and it worked out really well for me. So, as I said, there's lots of factors that influence what you do. But when you do go out there, it does make a difference to have that experience and just makes your life a bit easier, I think. We'll go to the next slide. So I thought I'd try and sell some people. If you are someone who has been in a rural area before or has enjoyed rural lifestyle, you're probably already sold. I certainly didn't want to work in a large area, just lifestyle-wise, so that it was quite easy for me to go into rural journalism. But there's a lot of people that haven't been in a rural place or may not enjoy working in a small place with limited resources, and also from a life perspective with your family and things like that, which is obviously some things that are unavoidable basically. But I think if you're not already sold, I think here are two good reasons why I think all GPs should train as RGs before returning to a regional or larger metro general practice, and that's for the skills and also the kind of the early wealth accumulation. That a lot of doctors aren't all that motivated for wealth, but some are, and I think it's important mentioning it. So skills. So I just looked on my phone for the last week or two and just picked out some photos. We're reducing fractures. This was 17-year-old, I think, that I reduced, and I was very happy with the reduction. I can barely even see the fracture line in the post-reduction film. Did that with like a manual cuff beers block. Used back in Bundaberg would have much more better equipment, but you'd be surprised what you can get away with. The middle one is an ultrasound of someone that came in with lumps in their groin, which just did a bedside ultrasound and see quite clearly that they've got these cystic structures, which turn out to be lymph nodes, and went on to diagnose them with quite an aggressive lymphoma. They're currently in hospital at the moment. And then the other one is a bit of as a joint aspirate from a lady that came in with ankle pain that I suspected was septic arthritis, and able to do that joint aspirate in the clinic and diagnose that, and she went on to have treatment. So these are all skills that you probably, like, we do these every day. Like, you know, we're like just the other day, like I took out a massive cyst off someone's skull. It was been there for 7 years, and you know, over a tennis ball in size. And then the next patient, I drained a Baker's cyst by ultrasound guided. And like the stuff that you just wouldn't, I would have never done those in regional general practice in Bundaberg, but doing these every day out in the bush. And those are the skills that, you know, I think are going to be very valuable, especially coming into a future where there are other, you know, non-medically trained people that are trying to encroach onto our jobs. These type of skills would set you apart. And then the last one, so yeah, early wealth. So the thing about working in two jobs is that you get two income streams, and then there's also the incentives, and then the low cost of living, and it all adds up to be, you know, a considerable amount of money that you do get. And like, you know, even as a registrar, you're earning, you know, definitely earning more than probably the vast majority of fellow GPs, and maybe even some non-procedural based specialists, even as a registrar. Just when you factor in everything at the end of the day. And you know, if you went out bush for a couple of years, you'd basically be setting yourself up for life, and it would make, you know, all these other points possible. Like, you know, buying a house these days is pretty hard, but and you don't have to wait, you know, 5-10 years of grinding it out in city general practice. You can be doing these things, you know, in the first couple of years, like getting a nice place, and setting yourself up for part-time work later in your career, and maybe even early retirement. And then obviously that'll equal spending more time doing what you love. Obviously, if that's medicine, then you can do medicine, or you can do other things. But I thought it is worth mentioning that because it does make a big difference.
Thank you, Travis. I think you've solved that. You might get an influx of people to Theodore soon. In the interest of time, I'm just going to move on to David, who's our rural generalist anaesthetist, and he's going to tell us his journey on becoming an RGA. We'll save our questions till the end. So, David, are you there?
Hello, is my microphone working?
Yep, we can hear you and see you.
Yeah, cool. Thank you for having me, everybody. Apologies, I don't know if my camera is actually on, but I'm a bit disheveled, come straight from theatre. I won't talk long. I appreciate that it's the end of the day, and I'm also looking forward to watching the Melbourne Storm destroy the Penrith Panthers imminently. So let's get on with it. A bit about me. I'm a rural generalist anaesthetist in South Australia. And I've got a couple other different hats. I am also the director of the Flinders. I'm a university academic, so I'm the director of the Flinders University South Australian Regional Training Hub, which is essentially a federal initiative looking at supporting, rural doctor training right across the journey from medical student to seasoned GP wherever we can in regional South Australia. And I'm also a non-executive director on the board of the country's South Australian Primary Health Network. For those of you that have been lectured by me before, this is not anything new. I like to front load, so put my take-home messages at the end of the lecture right at the start to frame the conversation. So in short, in summary, why rural generalism? In my book, number one, you get to do a lot of cool stuff. For me, not necessarily everybody, but for me, that's procedures. I love doing procedures, and my procedure choice is doing an anesthetic. And if you think about it, that is simultaneously a really cool, fun, interesting thing to do, which does a lot of good for people's quality of life and, can be life-saving at the same time. And if you think about it, that's a super massive paradox, because if you think about it, you are usually by giving somebody an anesthetic, by giving somebody propofol, you're literally purposely giving them a lethal medication, but in an exceedingly safe way to better their quality of life. That whole statement is a complete paradox, but it is really cool, really fun, and certainly something within your grasp if you choose rural generalism. Number two, as I said, you get to do a lot of good for a lot of people who really need it. The State of the Regions report by the federal government last year quite clearly showed that, it's not news. People in country areas have difficulty accessing good quality healthcare like those in metropolitan locations. That impacts in their quality of life, that impacts on their lifespans even. So there's a lot of room to do a lot of good for a lot of people who really need it. Number three, you'll find kind of resonant with the things that Travis was saying. There's not a lot that there's lots in medicine that you should be rightfully fearful of, but you'll find once you work as a country doctor and properly train as a rural generalist, there'll be not a lot that scares you that's not supposed to scare you. So essentially, with that kind of training, you have a passport to work and play wherever you want, anywhere in Australia, even remote parts, even rural parts. And there are some really cool places, in my experience, that you can work and play that are right next to the Great Barrier Reef, right next to the Daintree Rainforest, right next to the beaches of Eyre Peninsula. Number four, I want to really challenge everybody in this room, because I don't think this is something that's talked about, and this is a big bugbear of mine. There's a big emphasis on, you get to do a lot of good as a clinician in rural areas. That is not untrue, but at the same time, you'll find there's a lot of overlap in skills. Lots of the skills that you learn to do and use every day as a clinician also make you right for adding value for non-clinical jobs. So like, to give a couple examples there, you might find that if you are a damn good rural generalist, people approach you and say, hey, well, as a rural generalist anaesthetist, you know all about risk and benefit because you're having to make those life-saving or life-threatening calls all the time. So, hey, are you interested in being a board director on our board so you can take our company or our organization through risk and benefit to the benefit of everybody? Or similarly, you're a rural generalist, you have such a holistic view of how hospital care works and how outpatient care works. You're probably the best person to teach and train junior medical officers and medical students in a holistic way in an academic setting. Finally, the big other thing that I'm really not point number five there is to challenge myself, because this is something that even years into my career, I've been a country doc for almost 10 years now, and I'm still trying to get this right. Travis sounds like he's way better at it than me. Make sure, no matter where you work in rural, you find the right fit for you. And I've, made it big, made it bold, made it underline for your family as well. I've got 2 young kids, and I'm still trying to get that right to make sure that, as a rural generalist, I'm there for my family. Because if you don't prioritize that, looking after you and your family, nobody else will. Yeah. So, look, I'm just going to give some snapshots through my journey. Thereafter, I think the biggest value add is so you know a bit about where I've worked. And if you want to come have a yarn elsewhere, I'll leave my contact details at the end. That's probably the biggest value I can add tonight. So, starting off my journey, I did my rural generalist training in Port Lincoln, South Australia. And this, I really feel, this is a place I really feel is home. So I spent a number of years there. As you can see, there was plenty of fresh seafood, best tuna, best shellfish in the country, plenty of uninhabited beaches that you had all to yourself. And again, plenty of good to be done as a rural generalist, looking after populations that, to put things in perspective, were 650 or 700 kilometers even away from the nearest intensive care unit or pediatric unit. This is the other point I want to, and this is circling back to that take-home point I made before. Make it fit for you. Make sure you're in a place that fits for you. So the other fun thing about Port Lincoln is around about that time, my manager was actually, so I was DJing at the time as well, and my manager was actually getting some traction interstate. So I actually was during those years also going on tour interstate to, play nightclubs around the place, Oxford Arts Factory in Sydney, Fortitude Valley in Brisbane. And so I just wanted to make the point here, you make it fit for you. Find a town where you can do lots of good in the community, but if you've got other things going on as well, make it work for you. So in this case, Port Lincoln was a good fit for me because here's a place where I live 10 minutes drive from an airport that has 2 commercial airlines. So it wasn't a huge big deal. The other thing with this place was, I made sure that I was in a practice where I could trust that there were other clinicians there that could, look after people on my behalf when I wasn't physically on the ground. And I'd do the same for them, quid pro quo, when I got back. Fast forward now to 2021. This was Perry in the COVID pandemic, and I found, while I was having lots of fun in Port Lincoln, actually there were places down the road, so even further out. So now moving from MMM6, Modified Monash Model number 6, to Modified Monash number 7, and there were towns out there. So to put things in perspective, we're not talking about Port Lincoln, population of 15,000, but Streaky Bay now, population of 1,000, and even further away from the nearest intensive care unit, that were really struggling to have enough doctors to look after the community, particularly during COVID, where lots of them couldn't fly over to help out. So I found myself gravitating towards places like this later on in my career once I fellowed as a rural generalist. It is a bit more daunting. So in Streaky Bay, you go on for 7 days on, 7 days off, and in that 7 days on, you're literally the only doctor around for hundreds of kilometers around. So that can be potentially daunting. But again, there's lots of good to be done in areas like that. So clinically, that was a really good fit for me. And then again, you make it work for you. My interest, in addition to clinical work, is academia and teaching at the medical school. I was lucky enough to get a job at the world-class Adelaide Health Simulation Unit at University of Adelaide Medical School around then. So it made it such that, I'd do my 7 days off in Eyre Peninsula, then come back to Adelaide and work on simulation stuff in Adelaide. In that time as well, I made it work for me. I, for the first time in years, started up playing rugby again. So I got my footy in again, my 7 days off. And so don't get me wrong here, I'm not necessarily saying when you say make it work for you, only target those areas where you've got, lots and lots of doctors. I'm not saying that at all, but, if you are, take my example here, 1 doctor town, you make it work for you. And if the arrangement is such that you do a full 7 days of hard yakka clinically out in the regions, but the trade-off is then you have 7 days away from clinical to deal with your non-clinical duties, vie for a situation like that. Around about the Streaky Bay area, I was had a very eye-opening moment where I was on call. This fella came in to the emergency department. I'm the only doctor for several hundred kilometers around, and he'd had a massive brain bleed, and thereafter was not conscious enough to breathe properly. Got on the phone to Royal Adelaide ICU in Adelaide and said, just checking, just sounding off what we should do about this situation. And they said to me, "Duh, you need to intubate him." And I said, awkward. Let's say I hypothetically don't know how to intubate somebody. What should I do next? And they said, well, where's the next nearest doctor that can do that? I said, awkward, 100 kilometers away. And they said, oh, okay, awkward silence. So it was around about that time that I thought, well, look, if I'm going to be drawn towards doing good in communities that are that far out, where I'm the only guy on the ground, it probably pays to have some airway skills. I was lucky enough at that point to get a scholarship to go back and do some anesthesia training in far north Queensland. So that drew me to Cairns and Innisfail. And that was, again, just a wonderful time for us. Had lots of fun doing procedural stuff and upskilling with the mindset of these will be skills that will, hold me in good stead in communities that really need it. And at the same time, got to play a bit more footy there and got to do some really fun stuff outside of hours as well. There's not a lot of places or jobs that let you clock off after a hard day's work and then drive, and within an hour's drive, you've got the Daintree rainforest pictured there. You've got the Great Barrier Reef pictured there. All really fascinating, cool stuff, which is within your reach if you go down this path. fast forward to now, 2024 onwards, I'm back in South Australia. For context, when we moved to far north Queensland, it was one of the best times in our lives, but it was also one of the most hectic times in our lives. So we moved to far north Queensland in a flurry of myself and my heavily pregnant girlfriend landing on the ground in far north Queensland when we didn't know anybody, in the middle of a monsoon, in the middle of a COVID pandemic. Me starting work at the base hospital a couple of days later. A week later, we finally found somewhere to live. And a week after that, our son was born. So thereafter, when we were having our second child, my wife said, I'm not doing that again. We need to make this work for us. And we have some family support in regional South Australia. So off we came back. And it's been really lovely returning back to the state we called home for so long. Thereafter, I am doing my rural generalist thing, doing some anesthesia, doing some teaching at Flinders University Medical School, making it work for us. And I'll leave it there. The same take-home messages at the start. Why rural generalism? You get to do a lot of cool stuff and do a lot of good by a lot of people who really need it. It gives you a passport to do some cool stuff in some places, you know, some really cool places in Australia. Think about how your RG clinical skills can add value to non-clinical interests of yours. And for goodness sake, just make sure that you are going to something that's going to be the right fit for you and your family. My wife reported to me yesterday that I missed his bedtime. Sorry, it happens. And she said he was really confused because you were at a tutoring mentoring session, and then he said, Mama, where's Daddy? Is he at work? And she said, no. And he said, oh, is he at footy? And she said, no. And then thereafter, he got really confused because, my goodness, if he's not here or at footy or at work, where on earth is he? So I guess that's the thing that I'm trying to get my head around, and I'm really keen to learn from you all as well. You know, make it right for your family, and, you know, make sure they are always forefront of your equation as well. The picture there is my grandfather, who was a rural generalist back before it had a label. He did lots of cool things, superintendent Gympie Hospital. That photo there was when he was the medical director of the Commonwealth High Commission in Southeast Asia, and he was in charge of doing the healthcare, leading the healthcare for on behalf of Australia for all of the Vietnamese refugees coming in on the boats. I've left some contact details there. Feel free to email me. Feel free to get in touch via Instagram. The top one handle is essentially some snapshots of what happens in some of the regions that I'm working in. The bottom one is actually a podcast that my sister and my brother and I run with all our hot tips on how to pass your medical school exams and your fellowship exams. And I'll leave it there. Thank you for having me.
Thank you, David. There's a lot of valuable advice there. I'm going to call on Dr. Pip Knowler, because I think Pip is going to answer one of the questions that's in the Q&A, because she's a rural generalist with 2 additional rural skills. But before I hand over to Pip, just want to say we are running a bit behind, and we're going to try and address some of your questions. So for those who can't stay, feel free to go. But if you can stay and you have questions, hang on there. We're going to run a few minutes over, but we will get to your questions. So over to you, Pip.
Yeah, hi. So my name's Pip. I'm PGY7 with doing the RACGP's Rural Generalist program. So we can go to the next slide. Sorry, my slides are incredibly boring. I put them together very rapidly yesterday, so there's no pretty pictures, but just helps kind of outline my story. So I'm a bit different to the previous 2 in that I kind of came to rural generalism in more of a roundabout way. My journey through my career was initially quite linear. I did a Bachelor of Medical Science in South Australia. I'm from Adelaide as well. Then moved to ANU to finish that undergraduate degree, and then got into medicine there. And that was really my first taste of rural medicine. In Adelaide, I grew up sort of on the fringe of the city, so had no real exposure to rural lifestyle or anything growing up. But I was part of the Rural Society all through medical school, and spent the 3rd year of my training living in a town called Goulburn. And I just had a really great experience there, and it always just sort of was in the back of my mind. After graduating from medical school, I returned to Adelaide to do my internship, and I was very much in the city at the Royal Adelaide and the Queen Elizabeth. I moved back predominantly for family, which is, they all were all there. And I then stayed on to do 2 more RMO years. I wasn't really sure what I wanted to do with medicine. And I was actually quite interested in critical care initially. So my plan was just to try out lots of different things during the RMO years. I was quite keen on anaesthetics as a specialty for a while, and actually was accepted onto training, but was quite overwhelmed at the prospect of the exams and the competitive nature of it all. And so I decided to just give myself a break. I think I got kind of caught up in the competitive treadmill that you can in those junior years. And so decided I'd give myself a break and just really think things through. So I went to the Eyre Peninsula as well in Port Lincoln, and I spent 6 months there, and I worked with a GP anaesthetist for 3 months and just had such a wonderful time. And it really gave me a good glimpse into what that life would be like for myself. And it was just a way of seeing that you can combine all your different interests and have more of a balanced time through training and then after training. I also met a bunch of other rural generalists there, and I just thought they were the most incredible doctors. Like, there was one GP who had come to medicine as a mature age student, pursued rural generalism, initially did GP anaesthetics, and then decided she really was interested in obstetrics. And so she would be doing cases where she would put in the epidural herself and then deliver the woman's baby and then do all the antenatal care and postnatal care. And I just thought, that's the kind of doctor I wanted to be. So just met these amazing people. So after that, I applied to the RACGP and straight on to the program. I decided to start with South Australia. I think there's pros and cons to starting with your ARST in the hospital system as opposed to starting with community. But for me, this worked really well. It was the first time I was working at the registrar level, and that is quite a big step up going from resident to registrar. And so I think starting with an ARST was really helpful for me. And now that I'm in community practice, I'm really grateful to have had the longer sort of time kind of getting to community practice, because I feel much more comfortable working more autonomously. The hospital in Mount Barker is like the perfect learning place because you're not that rural. So if I didn't have any horrible brain bleeds that I would have to intubate, the retrieval team could get to us by road within an hour. So at worst, you were sitting with a sick patient for, maximum of an hour. But it was still rural enough that you would get some major emergencies coming in and you would have to manage them then and there before the retrieval team came up. So for me, that was the perfect amount. It really helped me build up a lot of practical skills and also confidence and in my own clinical practice. I still
We seem to have lost Pip. I think the internet is cut out.
The camping and all the good things about living here, but having a good job always helps facilitate a move. And I was lucky to get the role to do the anaesthetics IARST here at the Royal Hobart. Similar to David, whilst I sort of had the interest that I would work in general practice and anaesthetics, I really wanted to do the year as well to get the skills, because there had been a few moments in Mount Barker where I just thought, wow, I need more confidence managing airways and using medications to manage blood pressure and things like that. So it was just a really useful skill to get those, a useful year to get those skills as well. And it also gave me the opportunity to develop skills that I can now take anywhere, like doing epidurals and spinals and pain management and all sorts of skills that have been really helpful in general practice as well. From there, I just decided that Tasmania was the place for me. And so in a way that's also changed things a bit, because rural generalism is a bit different here in Tassie. Whilst the whole state is considered rural, we actually you can access a major hospital pretty easily. So there's not a huge need for certain rural generalist skills. So that is something that has been sort of said here. So in terms of anaesthetics, there's really only one hospital in the northwest that needs rural generalists, but there are still opportunities even in the more major centres. So I know 2 colleagues that do a day a week in the anaesthetics department at the Royal to maintain skills so that they can then go and use those skills interstate if needs be. It's similar for things like obstetrics as well. But on the flip side, I would say that maybe 50% of the Royal Hobart ED is staffed by GPs or GP trainees. So there's lots of opportunity to use your ARST in that aspect. And then similarly for Aboriginal and health, family planning and sexual health, pediatrics. So there's still lots of ways to use it all. I then the year after that, I stayed in Hobart and did my core ED term. So I did see there was a question earlier. And yeah, the RACGP, the rules are that you do have to do 6 months of emergency medicine in addition to your ARST if you choose emergency as your ARST. But you can cut time because you can use that core emergency term as your extended skills. So I haven't really lost time in that regard. I then after that decided I wanted another break. And so I took the rest of the year off and went traveling overseas and spent some more time with my family in South Australia. And so again, it just sort of hammers home how flexible the training pathway is. I had no barriers to taking time off for pure recreational purposes. The college was really happy to help with that. I've kind of sort of touched on those already. So yeah, I chose South Australia mainly to be back with my family, and then came to Tassie because I had a really good first impression whilst I was on a holiday. But I've stayed here for the lifestyle. If anyone's interested in Tasmania, I really would be happy to talk to you further. It's not only life outside of medicine, but the workforce culture here is fantastic. The ease of rural training, as I said, the whole state's rural, so makes it pretty easy. But it's just as a hospital system as well. I think I couldn't get her discharge summary, so I just called the hospital and I was speaking to a colleague that I work with in the ED, and it's just so lovely having that sort of you know people, you don't just feel like a cog in a wheel in a big system. So that's not, you have to sort of enroll in a certain state, but you can move and change your mind. It was really easy to arrange. I chose these disciplines, again, touched on this a bit. Emergency, really, I wanted that broad skill set and to get more confidence to work more remotely. Having seen what some of the GPs in Port Lincoln were managing, I just thought I would be so out of my depth. And so I wanted to build on that skill set. And I also figure in general practice, you get people walking in with all sorts of things. And you just think, why are you here? Like, you should be in the emergency department. So I just feel a lot more confident now, even in my community practice setting, having had that skill set. And that was a big driver for why I chose it. Anaesthetics, it was initially quite a specialised interest, and I'm really glad to have that skill set now and hope I will be able to use it. But I guess, like David was saying, like, what works for me is living here in Tasmania. So that was more my priority, but I'm really glad to have that skill set. On the next slide, so just a typical, I won't really go into any of the day-to-day stuff. I think Travis touched on that, the variety that you get, but just more a typical week for me. So again, just shows how flexible things are. So I'm technically working full-time at the moment, but I work 3 days a week in general practice, and I work one day a week in ED. So I end up having a 4-day weekend pretty much every second weekend. So that allows me to go and do those sort of things. And yeah, I haven't had to ask for any special requests. I haven't had to drop hours, and you can still have this incredibly flexible life, and that lots of my surgical and physician colleagues don't seem to get. So yeah, it's also nice to have that balance. And just one thing, if you do your ARST before you do your general practice terms, the RACGP allows you to do a day a week in your ARST as a maintenance of skills. So I am still working towards general practice at a full-time load, but actually one day of that in the skills that you've worked hard to develop. And then just the last slide on the next one. So just some sort of tips and tricks. So what I like about it, again, I kind of talked about this, but the variety. So having the variety, like within general practice itself, I'm really enjoying the chronic disease management. The continuity of care is incredibly satisfying, and much more so than I thought it would be, and building those relationships with your patients. And the variety within general practice, from chronic disease, doing skin biopsies, like sexual health and family planning and all sorts, but then having a mix of that with the acuity of emergency and anaesthetics is a really nice balance for me. I think one thing that in hindsight, I'm really glad to have pursued rural generalism is the flexibility to change my career as my life changes. So I think as a junior doctor, it's really easy to do night shifts and to let medicine sort of dominate your life a bit more. But as you progress through, your priorities do change. And the beauty of rural generalism is that you can adapt your career to suit your life, but still have a really rewarding and satisfying career. And you can pursue interests as you find them. So I've, in the last couple of weeks in general practice, have really enjoyed the sexual health side of things. And so there's the opportunity to do some work in the family planning unit here. And that was an interest I'd never been exposed to and couldn't pursue before. So I think that's a really wonderful thing about the career that I wasn't really aware of, and I'm really glad to have found. I think also one thing, just as a general tip, I know there's lots of medical students, is that when I think career counselling is really done that well in medicine, is that to look at the lives of your registrars, but more so of your consultants. I think the registrars, it's a shorter time, but it's the consultants, and it's their life that you should really look at, because that's what you're working towards. I have met so many rural generalists over the years, and they definitely seem to be the happiest consultants that I've met. They just seem really satisfied with their careers and what they've been able to do with their lives and the things that they've seen. And yes, I think that's a really important thing to do. And also, keep an open mind junior years, but there's so much more out there. And if you get the opportunity to do a rural generalist rotation as an intern or RMO, I'd really encourage it if you're interested in it, because it's very different as a medical student when you're just observing, but when you're there working with your patients yourself, you really get a taste of what it would be like as a career, and it might be something that really suits you. So yeah, happy to answer questions as well. Happy for my details to be passed on. Yeah.
Thank you so much, Pip. We might close the slides down and just get everyone on screen because of running over. Thank you to Jane, who's been busily typing away with some answers. I'm hoping that we've answered most of the questions, but there's 4 more still that we haven't addressed yet, and I'm happy to address them now. And if anyone else has any more questions, feel free to put it in there. And if any of our presenters have any other advice or tips they want to throw in there, let us know. But I can, feel all your enthusiasm and the passion in what you're doing and wanting to share it. So I was really keen for you to have as much time as you needed to share your experience. So we had a lot of questions on emergency medicine. I do want to answer one of these because it could be confusing if you're a GP registrar and you're working in the ED. You maybe a GP registrar on our training program, but you may be taking on a position in that hospital as a resident if you're doing your core emergency training, because you're not actually working at the level of an emergency registrar. So there's a distinction there. It's important that you understand that. And then there were some other questions about the emergency medicine courses. So if you do our program, it's very simple. Everyone has to do core emergency, so that's equivalent. In fact, it's a little bit above the level of the ASIM Foundation program. But once you've done that, you can actually enter into Pathway 2 towards their Advanced Emergency Training program. That's equivalent to the old Emergency Advanced Diploma. So if you do that, then you would be at the level of an advanced diploma. So you don't need to go back and do the 18 months of ASIM training, but overall you would have done 18 months. So I hope that clarifies it. And you can do more than one additional rural skills. Most people would only be able to complete one within their AGPT training time, but you can do as many as you like post-fellowship. And the funding from the government usually allows you to do one. If you're really quick and you complete everything within 4 years, you still have 2 extra years to complete your rural general. So you could potentially do more than one additional rural skills within your training time. But it's important that you pass all the exams, and you may need some extra time to do that. So what's the difference between RACGP, RG and FACRM? I'm going to throw it open to the floor. Would any of our rural generalists want to talk to that? Well, David or Travis, do you want to talk to that?
Yeah, I think at the end of the day, to be honest, it doesn't matter too much. You do the same work, get the same jobs. I think just the structure and the exams and the support is all a little bit different. Obviously, I can't comment too much with regards to ACRM, but I think in my mind, ACRM certainly is more of like, your hospital rural doctor, whereas I feel like RACGP is more of like a, your primary care rural doctor. But at the end of the day, they both pretty much do the same work.
Yeah, there's one ACRM don't have as much mandatory time in general practice. So I think you only have to do 6 months, as opposed to RACGP, you do have to do 18 months, which I personally think it's better to set you up, because you will be doing general practice kind of as in addition to your ARSTs. But that's sort of the main difference. But otherwise, the programs seem pretty similar, particularly like if you do emergency or anaesthetics or obstetrics as your ARST, you just all follow the programs as set out by the college. The exams are a bit more emergency medicine based is what I've been talking to about with my colleagues, but yeah.
Excellent, thank you. I think you guys have pretty much nailed it. I don't see. Oh, hang on. There's one more question. The question regarding interest in undertaking emergency special interest. Isn't association training? Yes. So the ASIM associateship is their advanced training is basically our ARST. However, you need to have the rural context as well. So even if you complete that, if you've only done it in a metro centre, you do need to get some rural experience doing your additional skills with emergency. So I think we've managed to answer all the questions. Maddie, are we done?
I think so. There were a few pre-submitted questions, but I do believe we'll be answering these offline and formulating a document or similar to share these questions. But if you do have any specific questions to yourself about niche situations, do reach out to the Become a GP email, and we will get back to you as soon as possible with some answers or pop you in the right direction of a medical teacher such as Karen herself.
Thank you very much. And thank you to Travis, Pip and David for joining us tonight and sharing their knowledge, and also to Jane, who's now been promoted to Dr. Jane, for giving us all her technical knowledge. And thank you to Maddie and Kate for preparing for tonight. And I hope you all gained what you wanted to out of this. And if you have any questions, contact our team on becomeagp@racgp.org.au. And have a really good night. Thanks, everyone.